Hi, everyone. Welcome. I'm Jamie Litterer, and I am the Outreach Director with our Clinical Affairs team at the Pulmonary Fibrosis Foundation. I want to welcome you to a special edition of our Pulmonary Fibrosis Foundation Disease Education Webinar Series. This month, our webinar is brought to you in partnership with the Pulmonary Hypertension Association. Before we get started, a few housekeeping remarks. This webinar is being recorded and will be available on the Pulmonary Fibrosis Foundation's YouTube channel for additional viewing at your convenience. All registrants will receive an email when the video recording is available. The slide deck for today's presentation can be found in the chat section down below. And if you need closed captioning, the option for that can be found under the More button. In the Q&A section of the panel, you can send any questions that you may have during the presentation. At the end of the presentation, we will have a question and answer session when both speakers are completed with their presentations. There will be a survey at the completion of today's webinar, and we would appreciate your feedback on the Pulmonary Fibrosis Foundation Disease Education Webinar Series. I'd like to take a moment and introduce the two excellent speakers that we have joining us today. We're joined by Dr. Anna Moniotis. Dr. Anna Moniotis is a board-certified pulmonologist and the co-director of the Pulmonary Hypertension Program at the Austin Heart Hospital. She attended the University of Michigan near her hometown in Ann Arbor, Michigan, and subsequently earned her medical degree from the University of Virginia. She completed her residency at the New York Presbyterian Columbia and her pulmonary and critical care fellowship at Brigham and Women's Hospital. She has served as a research fellow at the Harvard Medical School and published original research in lung transplantation. In addition to pulmonary disease, she is board certified in internal medicine and critical care medicine. She cares for patients with all types of pulmonary hypertension as the pulmonary director of Austin Heart Pulmonary Hypertension Program. And she's also involved in the greater pulmonary hypertension community, serving as an educator with the Pulmonary Hypertension Association and a participant in community events and patient support endeavors. In her free time, she enjoys cooking Greek cuisine and spending time with her husband and 3 children. We're also joined today by Dr. Christopher King. Dr. King is a transplant pulmonologist and the chief of cardiovascular critical care medicine at Inova Fairfax Hospital. He also serves as the associate medical director of the Transplant and Advanced Lung Disease Program, director of the cardiovascular intensive care unit at Inova Fairfax Hospital, the Pulmonary Fibrosis Foundation Center Director, and System Director of the Respiratory Care Services for Inova. He is board certified in internal medicine, pulmonary medicine, and critical care medicine. He serves as both a transplant pulmonologist and a medical intensivist for the Medical Critical Care Service at Inova Fairfax Hospital. He's an associate clinical professor of medicine at the University of Virginia School of Medicine. Dr. King is a member of the Medical Honor Society Alpha Omega Alpha, and while on active duty in the United States Army, he completed tours in Korea and Afghanistan, as well as serving in Virginia and Texas. He's participated in clinical research throughout his training and during his tenure at Inova. His research interests are broad and include venous thromboembolism, interstitial lung disease, and pulmonary hypertension. He has co-authored numerous publications, including original research and review articles. He has lectured at national conferences and currently serves as a panel member for the American College of Chest Physicians Guidelines on Antithrombotic Disease. Our speakers today will be presenting on managing pulmonary hypertension and interstitial lung disease, the symptoms, tests, and treatments. I do have to pause before we jump into our speakers' talks and issue a medical disclaimer. Please note that any information contained in this presentation is for information or educational purposes only. It is not intended to be a substitute for professional and medical advice. Always consult your personal physician or healthcare provider with any questions you may have regarding your specific medical condition. At this point, I'm going to turn the talk over to Dr. Moniotis, and please enjoy.
All right. Thank you, Jamie. So I am excited to be here today to talk about pulmonary hypertension and interstitial lung disease. So thank you to the Pulmonary Fibrosis Foundation, and also thank you to the Pulmonary Hypertension Association. And I'm just going to get these slides to advance. Okay, so there we go. And thank you for the very kind introduction. There you can see my name and Dr. King's name. And here's the medical disclaimer that Jamie discussed. One more disclaimer that I will add is that I've recently joined as a speaker for Liquidia Technologies. And the objectives that were given to Dr. King and I today were pretty straightforward with these three topics. So number one, signs and symptoms of PH-ILD. Number two, screening and diagnosis. And number three, treatment. So I will address the first two and then hand it off to Dr. King for the third. So before I start, I just want to make sure we go over the basics of the definitions, and some of this may certainly be a review for all of you, but I'd like for us all to be on the same page with the terminology. So when we say ILD, that's referencing interstitial lung disease, and that's a term for a group of disorders characterized by inflammation and scarring of lung tissue. IPF is idiopathic pulmonary fibrosis, and that is the most common ILD, and the idiopathic there references that there is no known cause. There are some established risk factors, including age, genetics, and some inhalational exposures. PH refers to pulmonary hypertension, and that is the elevated blood pressure in the artery that connects the heart to the lungs. And when you combine the two for PH-ILD, that means pulmonary hypertension due to having interstitial lung disease. So just to go into these definitions, these latter two definitions a little bit more, when we say elevated pressure in the pulmonary artery, we're talking about this artery here that leaves the right ventricle and goes into the lungs and throughout the lungs before then when it returns back, the circulation returns back to the left side of the heart. When the pressure in that artery is higher than 20 millimeters of mercury, that is the definition of pulmonary hypertension. So here's a graphic here where we're looking at this was made for in regards to idiopathic pulmonary fibrosis. So at the top, we have normal lungs, and then you can see that right next to these normal air sacs are the blood vessels. So they're immediately adjacent. With fibrosis of any kind, including IPF, but with any kind of pulmonary fibrosis, start to have what these white lines represent, which is a scarring process that happens adjacent to these airways. And this second picture doesn't show it, but you can see that this scarring process is going to be quite possibly involving these blood vessels or affecting these blood vessels that are right near the airways. And when that happens, you get changes to the blood vessels themselves. And this is a scientific picture, but I felt it was a good one to share today. It really gives the very, very close-up view. I mean, so we're looking, under a magnifying microscope here to see exactly what is happening to those blood vessels in the lungs. So the circle in the middle of the screen on the right, that's normal. And you can see that the dark blue part, and I don't know if you all can see my arrow, but this one on the left of the screen, there's this open space in the middle. And that open space, that circle in the middle of the screen, that's where blood can flow through. And when that vessel becomes affected by pulmonary hypertension, that space gets smaller. So you can see that there's less space, there's constriction. And when you're putting any fluid, and blood included, through a smaller tube, you have an increased resistance or an increased pressure. And this blood vessel, or this pathway for the blood, is made smaller by changes here in the blood vessel. So the blood vessel itself is getting thicker, and then changes to the lung tissue around it. So both the lung tissue and the pulmonary artery change, and that makes the blood flow through the lung more difficult, with the end result of PH-ILD, or the topic of our talk today. So just a side note that not all pH is the same. So if you hear the term pulmonary hypertension, or you Google it online or see brochures, wherever it is, not all is the same. So pulmonary hypertension is grouped into 3 groups. And the group that PH-ILD falls into is this 3rd group, so the one in the middle. So there is pulmonary hypertension that is considered to be idiopathic and heritable. There's pulmonary hypertension associated more so with heart disease or left-sided heart disease. And then there's pulmonary hypertension associated with blood clots or blocks in the pulmonary arteries. And then there's pulmonary hypertension that's miscellaneous causes. Those are not what we are talking about today. We are going to be talking about this one in the middle that has to do with associated with lung disease. And it's further broken down within that category to different types of lung disease. And so specifically, we're talking about PH associated with ILD. Okay, so now that we've got those definitions explained and reviewed, we'll talk about what are the signs and symptoms of PH-ILD. And when we're saying signs and symptoms rolls off the tongue, I think easier than symptoms and signs, but symptoms are the part that the patient presents with. And so as the patients are the most important here, I'm going to start with symptoms, and that's, we'll go here. So what are the symptoms? Well, for one of the things that makes the diagnosis or realizing that someone has pulmonary hypertension difficult is that there is a lot of overlap in the symptoms between PH and ILD. So ILD symptoms here on the left, we have shortness of breath, fatigue, exercise intolerance, maybe limiting how much you do because you know that you just can't do what you used to, and cough. Those first 3 are the first 3 that you also have in the earlier stages of pulmonary hypertension. So shortness of breath, fatigue, exercise intolerance, complete overlap. Cough is not particularly common in pulmonary hypertension, but if we're looking for the combination diagnosis of PH-ILD, that doesn't help us distinguish if a patient has ILD and has the cough, if they also have pulmonary hypertension. There are additional symptoms of pulmonary hypertension, such as dizziness, palpitations, noticing leg swelling or an enlarged abdomen, or syncope, or another word for fainting. These symptoms, however, come in later stages of pulmonary hypertension when that increased pressure in that pulmonary artery is starting to affect the right side of the heart. If you recall that picture I showed at the beginning where the pulmonary artery comes from the right ventricle, if that pressure gets high enough, it will start to put pressure or stress on that right ventricle. So these latter symptoms we see once we get to the point where the heart is being affected. And this is a good graphic showing that. So we have both a bar graph and a Venn diagram. So here with the blue oval is ILD, the purple oval is PH, and you can see that they overlap. And when they first overlap, we are still with these 3 symptoms of fatigue, shortness of breath, and cough. And it's only as we get further in time or further to the right side of the screen, and as the PH advances, that we get these additional symptoms of our what we call right ventricle failure symptoms, or RV failure symptoms. And that's the dizziness, fainting, and even more shortness of breath and even more fatigue. So our goal for our patients, and as physicians for our patients and for ourselves, is to be able to identify pulmonary hypertension before these additional symptoms develop. So one way to do that is to very carefully monitor those overlap symptoms. So this was a consensus statement or guidelines that were given by the Pulmonary Vascular Research Institute, saying that pulmonary hypertension should be suspected in interstitial lung disease patients when shortness of breath worsens in the setting of preserved lung function. So that's going to be, in the setting of the pulmonary function test saying the same, or the lungs, how they look on a CAT scan looking the same. So the testing for the lung function is stable, but the shortness of breath is getting worse. or when that shortness of breath appears to be out of proportion to the severity of the patient's underlying interstitial lung disease. So again, maybe the pulmonary function test or the CAT scan are showing, mild or moderate disease, but the shortness of breath isn't matching up with that. And so in either of those two scenarios where there seems to be a discrepancy in the symptoms and the characterization of the underlying pulmonary fibrosis or lung disease, that is a time to suspect or think about the possibility of pulmonary hypertension. So what are those signs? So those are the symptoms. What are the signs that your physician may look for, that they may look for on exam or on testing? So there are some physical exam findings, maybe some altered sounds when your physician listens to your heart, or signs of fluid retention, such as elevated fluid in the neck veins or leg swelling. Again, those physical exam signs match more with the more advanced stages of pulmonary hypertension. So those aren't as reliable in picking up the more early indications of pulmonary hypertension. The 6-minute walk results. So this is an objective measure of that question: is there something that has changed that is not related to the interstitial lung disease alone? So did the distance walked in the 6-minute walk decrease? Was there a change in the pulse oximetry or the pulse ox or oxygenation that doesn't seem to match what's going on with the pulmonary fibrosis? And then there are suggestive findings on various forms of testing. So we look at the pulmonary function test, and particularly the DLCO value. If the other parameters are stable or minimally decreased, but the DLCO has a large decrease, that would be an indication to say, oh, let's think about pulmonary hypertension. The CT scan, if the lungs look stable, the pulmonary fibrosis burden looks stable, but maybe the pulmonary artery looks bigger, or the ratio of the pulmonary artery to the aorta has changed, that's another indication or hint. And then some blood work, if there's signs that there's some blood markers for holding on to fluid or increased stretch of the heart, that might say, okay, there's something going on with the cardiac side outside of the lungs. So this is all of that I just discussed in a formal algorithm. This comes from a review or a summary from experts in the field. And they put everything that I just said in this flow chart. So up at the top, we have some of the symptoms and signs that I've been discussing, and then you combining those with some signs from the testing. So changes in the DLCO on the pulmonary function test, changes in the CT scan. Oops, sorry about that. Changes in the oxygen saturation and 6-minute walk test, or changes in the lab work. And the BNP and pro-BNP, that's the lab work that's in gray, just because that's not something pulmonologists will routinely get on their pulmonary fibrosis patients. That's something more so that may be an incidental finding, but PFTs, CT scans, 6-minute walk test, pulse ox, those are things that patients with ILD, their pulmonologists are going to be getting on them regularly. Okay, so part 2, screening and diagnosis. Okay, so now that we know, okay, these are kind of the symptoms that we're looking for, or the change in symptoms that we're looking for, and these are the signs on walk testing, or the signs on the testing results that we've been looking for. When do we do these? When do we evaluate for these changes in symptoms? When do we order these tests on the patients outside of the routine times that your pulmonologist is going to do these? Now, it used to be that looking for pulmonary hypertension wasn't a part of our pulmonologist's regular practice, and it was really only done as a part of the lung transplant evaluation. And that has changed with the new recommendations for treatment, which again, we'll get into later. But so the timing of screening is now moved up, but there's no definitive time that says, okay, you must be screened at this time. Currently, the expert consensus is to do early screening. So your physician may do it early when he or she meets you, or you early on in your course to say, okay, we've checked for it, we've evaluated for it, and this term low threshold of suspicion is there shouldn't be a big leap to say, or oh, we're waiting for everything to line up perfectly to check for this. So it's low threshold of suspicion early in diagnosis, and then really at any time that we feel that those symptoms or signs are changing, let's think about whether or not PH is the cause. And the one thing to note is that screening is recommended to be done at a time of relative stability. So yeah, that's not always something that can be attained, but if someone is acutely ill from a pneumonia or a new blood clot or something else that is happening, that is not the time to screen for pulmonary hypertension, because we may see a bit of pulmonary hypertension as that's more reactive to those treatable diagnoses or things that are happening that will resolve as the pneumonia or the blood clot or whatever, or the fluid retention, whatever additional medical issue is going on. But when that's treated, the pulmonary hypertension may resolve as well, because maybe that pulmonary hypertension is related to one of those other groups that I had talked about before. So the screening for pulmonary hypertension related to due to lung disease should be done when your pulmonologist feels the other medical issues are well managed. Again, here's the formal treatment algorithm that is recommended. And this is basically saying, okay, let's take all of these things that make us think about the possibility of pulmonary hypertension, the symptoms, the signs, the labs, and if our clinical suspicion is moderate or high, so for either of those possibilities, and then looking at where this red arrow points, let's do our screening test. And the screening test is an echocardiogram. So once that echocardiogram is completed, then there's a further stratification and whether or not the clinical suspicion is low or intermediate or high. And if the echocardiogram is very reassuring and it looks like this is not pulmonary hypertension, then the arrow goes to observe or reevaluate. It seems like, okay, the echocardiogram does not seem consistent with pulmonary hypertension. Maybe there's another cause for the change in the symptoms or another cause for why those test results are the way they are, and circle back and see what else could be contributing. But if the echocardiographic suspicion is intermediate high, you move on to the diagnostic test, which is the right heart catheterization. So this is just a slide on the echo, which is, I keep saying echo short for echocardiogram or transthoracic echocardiogram. And so this is an ultrasound done from the external part of the chest on the left side, and we get these images, these ultrasound images, and there's a whole set of criteria that the cardiologists who read these echocardiograms look at to say, okay, does this classify as low, intermediate, or high risk for pulmonary hypertension? And so we take the echocardiographic probability along with our clinical suspicion and helps us make the choice. So if there's a high probability on the echo and a high clinical suspicion, we're definitely moving to the right heart catheterization. That's what this RHC stands for. Even if the clinical suspicion is low, if the echocardiographic probability is high, we're still going to do a right heart cath. And you can see how this plays out. If the clinical suspicion is low and the echo suspicion is low, then right heart cath is probably not indicated, and an unnecessary procedure. For these intermediate cases where it says consider, that'd be a situation in which it would be shared decision making between the patient and the physician to say, is this procedure something that we should move forward with? So, what is this procedure? What is this right heart catheterization? And it's a procedure that directly measures the pressure inside the pulmonary arteries. So during this procedure, a doctor will insert a catheter or a thin rubber tube through a large vein. Usually, if we can, we'll do that through a vein in the arm, but sometimes it's the neck or the groin. And the doctor will then advance the catheter into the patient's heart. And there are certain points of advancement. So at different distances or different locations in the heart, the blood pressures are measured. So that's in the right side of the heart and in the lungs. And a right heart catheterization is the only way to confirm the diagnosis of pulmonary hypertension. So even if the echocardiogram is highly suspicious, the only way that is considered 100% confirmatory is the right heart catheterization. And so here, this is this yellow here in the center. That is what the catheter looks like. That's what's being advanced by your physician. And this is an example of entering through the vein in the arm and coming up through that vein into the right side of the heart and advancing through the right atrium or the upper part of the right side of the heart, the right ventricle, the lower part of the right side of the heart, and then into the pulmonary artery. And while that's being done, there'll be waveforms on a screen that your physician is looking at and recording. So these waveforms and the numbers are recorded and interpreted. And so if those numbers meet the definition of pulmonary hypertension, which again is a mean PA pressure of greater than 20. And then there's a measurement that's done at the end, which is looking at your fluid levels, if that's less than 15 millimeters of mercury. And then there's a calculation based on some of the numbers obtained, which gives the resistance. And when you plug those numbers into the calculator, if the resistance is greater than 2 Woods units, then that meets the criteria for pulmonary hypertension. And that's how we make the diagnosis. So again, if those results are consistent, the diagnosis is confirmed. And at that point, patients are evaluated for the role of treatment. And that concludes my 2 parts about signs and symptoms and screening and diagnosis. And we'll move on to treatment with Dr. King.
All right, can you guys hear me? So I just wanted to disclose I am a speaker for United Therapeutics, and they're one of the companies that makes really the only approved therapy for this form of pulmonary hypertension. And I've served on advisory boards for United Therapeutics and Merck. So, as was just pointed out, not all pulmonary hypertension is the same. And so when you're treating pulmonary hypertension, depending on the type that you have, the treatments can be very different. And so it's really important to do that right heart catheterization and make an accurate diagnosis, because if you try to use treatments that are specific for dilating the blood vessels, like we do in this form of pulmonary hypertension, and you give it to patients with left heart disease, you can actually sometimes make things worse and make people feel worse. And so you really want to, make sure you're diagnosing accurately and treating the correct population. Why are we talking about pulmonary hypertension and interstitial lung disease? It's really an impactful diagnosis. And so it makes people feel worse and it shortens their lifespan. These are all different kinds of pulmonary hypertension. So PAH that's group 1 pulmonary hypertension. PVH is pulmonary hypertension associated with left heart disease. And you can see the survival in terms of months. And so down here at the bottom is lung disease associated or group 3 pulmonary hypertension. And so you can see by 5 years, only about 40% of patients are still alive. And so it really has major implications on lifespan. And it also makes people feel worse. It's associated with an increased need for supplemental oxygen, and patients just simply can't walk as far. And so if you look at patients that had pulmonary pressures less than 25 millimeters of mercury, which was the sort of prior definition, it's since been lowered to 20, but they don't walk as far, and they need more oxygen. And even mild pulmonary hypertension is impactful. And so in this study, this is no pulmonary hypertension up at the top, but even sort of borderline pulmonary pressures. And some studies say a mean pulmonary artery pressure greater than 17 millimeters of mercury is associated with worsening outcomes. And so and the groups lived about the same amount of time, whether they had mild pulmonary hypertension or severe pulmonary hypertension. Now, overall, severe pulmonary hypertension does do worse, but even borderline or mild pulmonary hypertension in the setting of interstitial lung disease has major impacts on survival. So pulmonary hypertension associated with interstitial lung disease is bad. We have all these great drugs to treat pulmonary arterial hypertension, and so it seems natural, like, to try out these medications. And unfortunately, that happened for a long period of time, and it just didn't pan out that they were able to demonstrate benefit. In fact, there were a number of studies that really showed no benefit, and some that showed harm. And so even now that we have a randomized controlled trial, which I'll talk about later in the next few minutes, it's still a little bit controversial. I think some people aren't 100% believers in the benefits of pulmonary vasodilators and pulmonary hypertension associated with interstitial lung disease. But there are some sort of principal tenets of treating pulmonary hypertension that we all agree on. And so the first thing is that you really have to, again, make an accurate diagnosis. It's hugely important, and you want to make sure that you're not treating patients with left heart disease inappropriately with pulmonary vasodilator medication. And again, you have to have that properly performed right heart catheterization, which sometimes is easier said than done in patients with interstitial lung disease because the way that they breathe, it affects the tracings, and it can be difficult to get accurate information. So you want to make sure it's done at a place that has experience in doing those heart catheterizations on patients with underlying lung disease. Other things that we can agree on, you should really rule out other causes of pulmonary hypertension. You want to treat patients with diuretics if they have fluid overload. You should look for and treat sleep disordered breathing. You want to look for oxygen desaturation and supplement with oxygen if found. Pulmonary rehab is a great thing that makes people feel better. It improves quality of life, and so because patients with pulmonary hypertension associated interstitial lung disease have a tendency to get deconditioned, and so making sure that they get that referral to pulmonary rehab. Vaccinations. Make sure you're treating the underlying lung disease appropriately. If patients have anemia, that should be corrected. And you really want to, if patients are transplant candidates, make sure they get referred for lung transplantation. In fact, as I mentioned, it's there's such a poor prognosis associated with pulmonary hypertension associated with interstitial lung disease that the International Society of Heart and Lung Transplant actually lists development of pulmonary hypertension as criteria for active listing for lung transplantation. And then it's best to be seen at an experienced PAH center for evaluation and treatment. This is a little bit of an aside, but I looked for other things that everybody can universally agree on. And fortunately, Oprah was kind enough to help me out. And these are some of the things that everyone can agree on besides these things that I mentioned about pulmonary hypertension, that babies in glasses are super cute, that Rose had enough room on the floating door for Jack in the movie Titanic, finding $20 in your coat never gets old. And so the healing power of interspecies friendships, I think if you see like a cat and a bird or something that are friends, apparently super cute and good for everyone. So what about pulmonary vasodilators? I mentioned it was somewhat controversial, and we had a lot of studies over the years, and most of the data that came out over time were these small observational studies or registry data. But there were, when they tried to do well-designed randomized clinical trials, it was difficult to demonstrate a response. It's always tough because it's a relatively uncommon disease. And then patients with this are quite sick. So a lot of times, rather than putting their patients into studies, physicians felt like it was better to treat off label. And so it was difficult to populate studies. And then patients would decline relatively quickly. And so, and end up getting transplanted and things. And so there were high dropout rates. And then it's also easy to, enroll patients with the wrong kind of interstitial or the wrong kind of pulmonary hypertension, et cetera. And so lots of reasons, for failures with these clinical trials. But there's only been really 5 randomized controlled trials in patients with right heart catheterization confirmed PH ILD. The yellow ones that are highlighted, one was an inhaled drug, and then bosentan is an oral drug, were kind of neutral studies. And the red trials actually demonstrated harm. And so there's really, 4 classes of medications in pulmonary hypertension now. There was, for the longest period of time until a new medication called sotatercept came out, there were really these 3 big categories of drugs. And so ambrisentan and bosentan are in one class, riociguat and sildenafil, et cetera, in another kind of class of medications. And then prostanoids are that 3rd class. And so this trial was terminated early for harm, and riociguat as well, even though there was a promising sort of earlier study, got terminated for harm. And so these medications specifically are not recommended for use in pulmonary hypertension. And we'll talk in a moment about this treprostinil trial that's mentioned last, but that's the only trial that's been able to demonstrate benefit, and inhaled treprostinil remains the only FDA-approved treatment for pulmonary hypertension associated with interstitial lung disease. So, all these different trials over the years, some maybe suggested some benefit, some were dismal failures, but then along comes this the INCREASE trial, and so that led to the treatment. And so, how was the trial conducted? It was a multi-center placebo-controlled trial. You had to have a heart catheterization to confirm the diagnosis, and they randomized patients. Half the patients got drug and half did not. So a true sort of placebo-controlled trial. It lasted for 16 weeks, and patients got their inhaled treprostinil via this iNeb device. And so there's other ways to deliver inhaled treprostinil that I'll talk about at the end, but this is what was used in the clinical trial. And the primary endpoint that they were looking at for benefit was how far could people walk on their 6-minute walk test distance at week 16. There was a number of sort of secondary things that they looked at as well. And the groups were the same when they randomized, so they did a good job with that. So there were really no big differences between the groups. And they enrolled patients with a lot of different kinds of interstitial lung disease. And so it seems like it can be used in regardless. It doesn't just have to be idiopathic pulmonary fibrosis, chronic hypersensitivity pneumonitis, occupational associated lung diseases, combined pulmonary fibrosis and emphysema, and connective tissue disease associated emphysema were all represented in the clinical trial. And you could see like these populations, maybe didn't have the connective or combined pulmonary fibrosis and emphysema. Was a particularly problematic population in some of the other clinical trials. And many people think the one study that was negative, that RISE IIP study, it was because of these patients with emphysema not responding well to the treatment. And then again, connective tissue disease did make up a significant portion of the trial. So this is what they looked at, and they found, that patients. I'm sorry, this is their baseline characteristics. So they were fairly sick. They had a relatively high pulmonary vascular resistance of about 6, and pulmonary artery pressures that are over 35. So pretty sick patients with pretty severe pulmonary hypertension in both groups. And so what did they find? This is the walk distance. There was an improvement of 31 meters if you look at the difference between the placebo group and the inhaled treprostinil group. And so over that 16-week period. And so the patients that were in the placebo group tended to get a little bit worse, whereas they sort of increased and stabilized in the inhaled treprostinil group. I think it's worth pointing out again that this treatment, it's not a dramatic improvement that people feel. Like when we treat patients that are newly diagnosed pulmonary arterial hypertension patients, they can have a pretty significant improvement in their symptoms, really feel much better. Whereas in patients with pulmonary hypertension associated with interstitial lung disease, I think it does stabilize patients. I think their functional status improves a bit, and I think it keeps them from kind of going downhill over time. But it's not a dramatic response where they're taking off their oxygen and they so that you should still continue to refer these patients for lung transplant evaluation and all those things that I mentioned earlier. So what about other secondary endpoints? They had a number of things that improved. So the BNP levels, which are kind of a marker of how stretched out the heart is, and they're strongly associated with how patients do with pulmonary hypertension. It decreased in patients with inhaled treprostinil, whereas it increased in the placebo group. You can see here they looked at clinical worsening events, and there were more clinical worsening events in the placebo group than in the other, and that was primarily made up of hospitalization and a decrease in the 6-minute walk distance of greater than 15%. And so, there were adverse events associated with the use of inhaled treprostinil, which is not surprising because these medications, they do have kind of predictable side effects. And one thing, it didn't reach statistical significance here, but cough was fairly common. And I will say, like anecdotally, like when you treat patients, cough is a fairly common complaint after use of treprostinil. They also had kind of throat pain and irritation, so those were significant differences and relatively commonly reported, but not too severe. And there wasn't a major, there weren't a lot of serious events, and there weren't a ton of patients dropping out. 47 in the inhaled treprostinil group and 38 in the other group. And so again, this clinical trial led to inhaled treprostinil being an FDA approved treatment. There's a lot of, they kind of followed out the data and did a lot of other things with the study. So this is looking at those clinical worsening events as patients, over time, they tended to stack these events. And so by continuing on medication, inhaled treprostinil not only, had that sort of primary endpoint, but when they followed patients out further on, they were able to avoid, death, decline in their FVC, hospitalizations, et cetera. But patients that weren't on therapy continued to have all these clinical worsening events. A lot of people talk about, should you treat all patients or only the severe patients? And so, in the group where the patients had less severe disease, there wasn't really a statistically significant difference in terms of patients with inhaled treprostinil functioning better. And so this has led some people to say, like, don't really treat patients that don't have severe disease with a pulmonary vascular resistance less than 4 Wood units. Although I would maybe push back on that, and I tend to treat, because most of those patients will progress over time. And there's been some subsequent work where they looked at the patients that had like lower pulmonary vascular resistance, and if you follow them over time, they ended up having clinical events, and earlier treatment. Actually, those patients did ultimately benefit from it in these sort of post hoc, like the studies, kind of like additional analysis of the data that was came from the study. So there's pulmonary hypertension guidelines, and this is what they say about the use of pulmonary arterial hypertension medications. And they say It's not recommended in patients with lung disease and non-severe PH in general. But inhaled treprostinil could be considered in patients with pulmonary hypertension associated with interstitial lung disease, and they kind of they don't have a caveat about the severity of PH, because patients in that clinical trial that we mentioned, they had a mean pulmonary artery pressure greater than 25, and so they could still have mild pulmonary hypertension and still seem to potentially benefit from it. Phosphodiesterase 5 inhibitors are another class of medications that are sometimes utilized in this condition. And sildenafil specifically, there's registry data, and a lot of places in the world, inhaled treprostinil is just not available. And so these guidelines are really intended for a global audience, and they're European guidelines specifically. And so they do tend to use sildenafil, which is an oral pulmonary hypertension medication in other places and severe PH. I think you'll see that done in the U.S. as well. Oftentimes, if I use inhaled treprostinil as first line therapy, but if patients can't tolerate it or due to side effects or something, I will sometimes use sildenafil as an additional therapy. Or if patients have very severe disease and they're not optimized on inhaled treprostinil, I'll sometimes add sildenafil and kind of monitor carefully. They did recommend against the use of that class of medications in non-severe pulmonary hypertension. So I mentioned there, I showed you the iNeb, which was the device that was studied. There are two companies, United Therapeutics and Liquidia, that now have a much easier to use form of treprostinil, which comes in this dry powder inhaler form. And so the iNeb, you have to clean it and you have to charge the batteries, and it's a little bit more time consuming. Whereas the dry powder inhaler, it's like a little capsule you insert and crush and inhale. There's also a company called Insmed, and they've just announced development of a once-a-day inhaled treprostinil. It's not commercially available yet, and I don't know, the study that they did for that medication was done in pulmonary arterial hypertension patients, although the FDA approved one of the dry powder inhalers without specifically studying it in an interstitial lung disease kind of population. And so it'll be interesting to see if this becomes an option, because once a day treatment, I think, seems very appealing. And so I think, so hopefully, ongoing treatments will become available. But you can see with all the trouble that we had getting to this first approved medication, it's not clear that just because drugs are being studied that they're gonna benefit or result in benefit. I think that does it for me. I will open it up for questions. Just wanted to thank the PFF and Pulmonary Hypertension Association for having me and for putting this together.
I want to thank you, Dr. King, and you, Dr. Manidanis. Thank you so much for taking your time today and sharing all of this information with our group of attendees today. It's really important, and I know you're both very busy, so we really appreciate you taking the time both today with us and the time that you invested in putting these talks together. So thank you. We have a couple questions from people that are in the panelists in attendance today. And one of our questions was, when we're looking at an echocardiogram, how variable is it when we estimate that pressure compared to what you would actually get on a right heart cath?
It can be variable. There's a lot of studies that have shown that you can either over or underestimate pulmonary pressures when you're looking at echocardiogram. And then I mentioned that even mild changes in your pulmonary pressures can have a meaningful impact on outcomes and on symptoms. And so those modest elevations in pulmonary pressures don't often translate into significant changes in the right heart. And so you have to have a pretty high index of suspicion. And as Dr. Maniotis mentioned, you want to be looking at all these different pieces of data that you're getting to have sort of a high suspicion for it, and sometimes that'll lead to referral for right heart catheterization, even in the face of a relatively normal echocardiogram. I don't know if you want to further expand on that.
No, I just say I completely agree with that. There are limitations for the transthoracic echocardiogram, body habitus, but especially in patients with lung disease, the lungs are on either side of the heart. So if there are significant abnormalities in the lung tissue, that can affect how accurate those ultrasound images are. So I did not put it in my talk because it is quite technical, but there's a defined set of criteria in regards to not just the RVSP, but other factors on the echocardiogram that can increase the suspicion or decrease the suspicion. And all of that data goes into the decision making.
Great, thank you both. Another question that we had is about how often should patients be screened for pulmonary hypertension?
And I think I sort of answered this in the text because that was directly a part of my talk. As far as I know, right now there is not an agreed upon frequency, and it's this approach where you take in all of these different pieces of data based on the clinical course and how signs, symptoms, test results. I think some pulmonologists will borrow from our rheumatology colleagues. So they have some recommendations for scleroderma patients who are at high risk for PAH or the group 1, and also at risk for PH ILD, depending on the type of scleroderma, and screen annually. So there are some pulmonologists that will do that, but it's really a question that can't be answered for everyone. So it really depends on the underlying diagnosis, type of ILD, and the tempo or of progression or lack thereof.
Perfect, thank you. We've had a question too about lung transplant and if having pulmonary hypertension can alter the outcomes for lung transplant patients.
Overall, patients with pulmonary hypertension have similar outcomes. There is an increased risk of something called primary graft dysfunction, which is kind of like this, like you get the lungs get a little bit leaky, and you can have higher oxygen needs earlier on after transplant, like in the first 72 hours. But generally speaking, sort of long-term outcomes are relatively equivalent in patients with pulmonary hypertension versus not.
Great. And then another question came up about pulmonary rehab. I know you touched about it in your talk, Dr. King, but can we revisit what the benefits are for patients with pulmonary hypertension attending pulmonary rehab?
Sure. No, so pulmonary rehab is like an organized exercise class that's usually about 8 weeks long and is typically about 3 sessions a week early on. A lot of them have maintenance programs where you can go twice a week or so after that. And some of it is education and some of it is just exercise. But I think it's hugely helpful. Patients get deconditioned. And then there's also, like, when you're short of breath, I think you feel kind of unsafe or don't know how hard to push yourself. And so because you're there, you're being monitored, it can help people kind of exercise, I think, more aggressively and overcome some of that deconditioning that they have. And so it's been demonstrated to improve quality of life and shortness of breath. And for a long time, there was concern about having patients with pulmonary hypertension exercise, but they are actually found to be a group that gets significant benefit from it, and maybe more benefit than other groups. And so it's not been specifically studied that well in pulmonary hypertension associated with interstitial lung disease, but interstitial lung disease and pulmonary arterial hypertension have both been studied, and I do think it's beneficial in pulmonary hypertension associated with interstitial lung disease as well.
Great, thank you. And then let's see, I think we probably have time for about one more question. So let's see what we have here. So there's a question about if there are new drugs on the horizon.
Go for it.
Oh, I'll start. So just recapping Dr. King's last slide about some of the inhaled medications that are out. The alternative for inhaled Tyvaso is now recently available, and I think everyone is hoping that there will be ones. All of the available inhaled options right now are 4 times a day. Some will say you can do 3 to 5, but in general, the goal is 4 times a day. So we're all hoping for one that is less frequent, and the news that there's one that may be coming is great. The other thing is that the dry powder inhalers, both of them, Tyvaso and Yutrepia, we don't have a whole lot of data in those for the ILD patients. The study was with that nebulized version, so we're hoping to get some more information coming soon in terms of how to best use the dry powder inhalers that we have.
There are some clinical trials going on of other sort of medications, and whether sotatercept will be applied in the group 3 pulmonary hypertension population as well. I think it would be intriguing to see if it works. It's been a sort of a game changer in pulmonary arterial hypertension, but there are some clinical trials underway of novel agents. We'll have to see if they pan out. It's for the patient studies to get fully enrolled and get through, and then a lot of them are more phase 2 type studies, and so I don't think there's any therapeutics that we're going to see in the short term, but I'm hoping. There's been a lot of development in the last 5 years in pulmonary hypertension associated with interstitial lung disease, so hopefully that trend will continue.
Great. Thank you both again. We really appreciate you being here with us today. Dr. King, I'm just going to ask you to forward to the next slide for me. Perfect. Thank you. We just wanted to take a moment to thank our sponsors for today's disease education webinar. BI and Genentech are sponsors of our webinar series. And then today we have some additional sponsors for the Pulmonary Hypertension ILD talk today. So we really want to thank Gossamer, Insmed, and United Therapeutics as well. So we appreciate their sponsorship of our talk today. And then lastly, as we begin preparing for Pulmonary Fibrosis Awareness Month, which is coming up in September, we wanted to invite you to participate in raising awareness with us. We want to invite you to be a light for pulmonary fibrosis in your community. So this September, join the Pulmonary Fibrosis Foundation in raising awareness by helping us light up landmarks and buildings across the country in our Pulmonary Fibrosis Foundation Blue. So as we celebrate the foundation's 25th anniversary, we're going to ask you to be our partners and volunteers and reach out to local buildings or landmarks where you live and ask them if they'll light up their building in blue during September, whether it's one day or throughout the whole month. Our goal this year is really bold. We're aiming to add 250 sites nationwide, which would far surpass our previous participation records. All participating locations will be featured in our National Blue Up for PF campaign, helping bring visibility to the more than 250,000 Americans living with this life-threatening lung disease. So reaching out is easy. The Pulmonary Fibrosis Foundation already has a letter templated for you. You can find that on our website to request a building to participate in this. And you can also contact the PFF Help Center for more information. If you do find that a site in your community is going to participate, be sure to let us know so that we can make sure to feature them on the list of buildings that are participating. And then new this year, we're inviting individuals to light their homes blue to expand our campaign's impact even further. So we'll have city landmarks and neighborhood homes, and every light will help raise awareness and show that the PF community is supported and seen. So let's get the entire country shining blue this September for our loved ones, for our community, and for a cure. And with that, it brings us to the end of our session today. So we will see you in August for our next PFF disease education webinar. Thank you, everybody.